Hi, I'm Lila Urogdy, and I'm studying biopsychology, cognition, and neuroscience at the University of Michigan. Welcome to my podcast, Neurobites, where I break down new and significant research about psychology, neuroscience, and mental health topics in order to make research more accessible to the general public. If I say something you disagree with or believe to be false, I encourage you to reach out and initiate a discussion with me. Let's get into the episode. A couple weeks ago, a few people requested that I make an episode about trauma. I've also briefly mentioned it in some of my previous episodes, so I finally decided to make an episode to discuss what post-traumatic stress disorder is, how it impacts the brain, and where the field is currently at in terms of treatments. It's important that you understand what trauma is and how it impacts the brain because chances are you or someone you know has or will at some point experience a traumatic event. All sources used to create this podcast will be listed in the show notes. Just a reminder, I'm not a doctor, and this episode is for educational purposes only. Please do not diagnose yourself with any disorder or change any treatment protocols without speaking to a doctor first. Okay, now let's talk about PTSD. When someone experiences or witnesses a traumatic event, they may be haunted for the rest of their life through flashbacks, nightmares, and hypervigilant responses to stimuli, culminating in the development of post-traumatic stress disorder, or PTSD. However, scientists have yet to fully understand why some individuals develop PTSD, while others seem not to be affected by potentially traumatic experiences long-term. Formerly known as shell shock, referring to the PTSD symptoms observed in World War I veterans, PTSD was first listed as a formal diagnosis in the 3rd edition of the Diagnostic and Statistical Manual of Mental Disorders, or DSM. In the latest edition, the DSM-5, the 5th edition, the criteria require that an individual has experienced, quote, exposure to actual or threatened death, serious injury, or sexual violence, unquote, through either direct exposure, witnessing the event, learning about the event that happened to a loved one, or repeated exposure to an event. In the criteria, the DSM-5 also lists common symptoms such as distressing memories, dissociation, nightmares, flashbacks, and avoidance of stimuli related to the trauma. In order to make this information easier to understand, I'm going to create a fictitious PTSD patient. This example is completely made up, so any connections to real-life people or events are purely coincidental. Okay, so let's say we have a woman named Lucy. Lucy and her husband were driving their daughter's... Okay, so let's say we have a woman named Lucy. Lucy and her husband were driving their daughter to soccer practice one day when another car blew past a stop sign and crashed into the door where their daughter was sitting. Unfortunately, the daughter wasn't wearing her seatbelt and the accident was fatal for her, but Lucy and her husband survived. For months after the accident, Lucy has nightmares about the crash and fears driving. Little sounds startle her, and she experiences frequent flashbacks. She hasn't driven since the crash, which causes her to lose her job. On the other hand, Lucy's husband grieves the loss of his daughter, but he's able to function and doesn't experience the nightmares or flashbacks that Lucy experiences. Her husband takes some time off work, but he's able to go back after a few weeks and doesn't fear driving, although he's a little bit more cautious when he drives. This is an example of how trauma, even the same traumatic experience, can affect different people in different ways. In a few minutes, I'll return to this example, but for now, let's look at the history of the PTSD diagnosis. According to Yehuda and colleagues, since the 20th century, the diagnostic criteria for PTSD have evolved as scientists continue to conduct comprehensive studies of various at-risk populations. Large-scale longitudinal studies were carried out during the Vietnam War, allowing researchers to determine the prevalence and severity of PTSD symptoms in wartime veterans. So if you don't know what longitudinal means in this instance, it basically means that these studies were carried out over a long period of time, and veterans were followed and studied over multiple years, as opposed to having a short study that only lasts a couple months. So that's what longitudinal means in this case. More recent studies were also done to assess PTSD rates in war veterans who had fought in other countries such as Iraq and Afghanistan. These studies found that the level of exposure to the traumatic event played a huge role in the severity and duration of PTSD symptoms. Additionally, they found that PTSD resulting from military service is often a chronic condition, meaning that trauma can have a long-term impact on an individual's life. This is why it's so important to develop treatments for PTSD. Outside of military-related trauma, studies have found that the majority of the U.S. population as a whole, and about 70% of U.S. women, have experienced one or more traumatic events at some point in their life. However, what's interesting is that most of these individuals never develop PTSD. Therefore, the question that arises is, why do some individuals exposed to a traumatic event develop PTSD while others do not? Going back to our example, why did the car accident have such an impact on Lucy but didn't seem to affect her husband? To help answer this question, I dove into the scientific literature. As with most psychiatric disorders and most health conditions in general, there are genetic, biological, and environmental factors at play. A twin study published in 2002 by Stein and colleagues investigated the heritability of PTSD. The researchers found that genetics can influence both exposure to the trauma itself and PTSD symptoms, concluding that PTSD is moderately heritable. I found it interesting that genetics can play a role in one's vulnerability to being exposed to a trauma, not just developing the symptoms after the trauma. The researchers hypothesized that this may be due to heritable personality traits that may influence decisions about what a person does in certain places and what environments people are put into. So if someone is related to someone else, they might have personality traits that make them more likely to be in certain environments compared to others. So if you have a super risky, super bold personality, you might put yourself in more risky situations, and this could lead to a traumatic experience, potentially. Or maybe you're really impulsive and you drive really fast, and so this puts you in situations where you are more likely to get into a car crash. And so if you're related to people who are also impulsive like this and they're also driving fast, they also might be more prone to being exposed to an event like this. There's also evidence that higher levels of brain-derived neurotrophic factor, or BDNF, is correlated with increased resilience to PTSD, meaning that an individual would be less likely to develop PTSD following exposure to a trauma or experience less severe symptoms if they have higher levels of BDNF. According to a paper published in 2016 by Cataneo and colleagues, I'm sorry if I'm mispronouncing that name, BDNF, quote, regulates the survival and growth of neurons and influences synaptic efficiency and plasticity, unquote. So basically this means that BDNF supports existing neurons and the growth of new neurons, as well as plays a role in the changes in connections between neurons. This plasticity might make someone a little more resilient and less likely to develop PTSD. In January of 2025, Bonnie Quigley and colleagues published a paper highlighting this correlation, finding that higher BDNF levels were associated with less severe PTSD symptoms, suggesting BDNF as a potential biomarker for resilience. As always, the link to this paper is listed in the show notes. Another possible explanation for why some individuals develop PTSD is that the amygdala becomes hyperactive when fear extinction fails after fear conditioning. I'll talk about a paper that discusses this in a moment, but first, I'll break down what some of these words mean because they might be a little confusing to you. So you probably already know what fear conditioning is, even if you don't know the name for it. In simple terms, fear conditioning is training a person or animal to have a fear response after a particular stimulus that was previously neutral. In animal experiments, this could look like playing a sound, such as a beep, and then giving the animal a foot shock. After repeated trials, the animal would begin to have a fear response after hearing the beep in anticipation of the foot shock. And eventually they would have this response even if there wasn't a foot shock after the beep, because they were conditioned to have a fear response following the beep. The foot shock is what is called the unconditioned stimulus, because no training needs to be done for the animal to be scared after receiving the shock. In general, when an animal receives a foot shock, they have a fear response. And so this is an unconditioned response. The beep would be called the conditioned stimulus because at first a beep is a neutral stimulus. Normally, hearing a beep does not elicit any fear response. And it's neither aversive nor rewarding. However, after fear conditioning, the animal has been conditioned to respond with fear when they hear the beep. So that is basically a long-winded way of saying that if you pair a neutral stimulus with an unconditioned stimulus, you can eventually condition an animal to have a response to the neutral stimulus. If this idea is still a little bit confusing to you, I'm going to try to break it down a little bit more and provide a more tangible example that you might have experienced yourself. And this example is not necessarily a fear conditioning example in particular, but it's just an associative learning example, just in general. Associating two things and kind of having an altered response because of it. So imagine that there's a food that you eat sometimes, but you don't love it and you don't hate it. It's not particularly rewarding and it's not particularly aversive. So you have this food and one day you get sick. You have the flu. It has nothing to do with the food itself, but you have the flu and you're feeling nauseous. And you eat this food that is normally neutral for you, and it normally doesn't create any special response, but you have nausea because of the flu. And so you are associating this feeling of nausea with the food that you ate. And so now you don't want to eat that food and you no longer like the food because you felt nauseous that one time when you had the flu when you ate it. So this would be an example of associative learning. Fear conditioning is a type of associative learning. So that's why I'm providing this example. So hopefully you kind of understand fear conditioning a little bit more and understand the idea of associative learning. Fear extinction is essentially the opposite, where the animal would unlearn the fear response. So to do this, the researchers would repeatedly play the conditioned stimulus, which is the beep, without the foot shock, which would eventually get rid of the fear response associated with the beep. So if we go back to our food example, if you eat that food that you felt nauseous after eating that one time, if you continue to eat that food and you don't feel any nausea after that, then you might begin to like this food again. So that's a general overview of what fear extinction is. Now, it's not necessarily fear that you're feeling when you're feeling nauseous with the food. That's just kind of associative learning that I'm talking about. The specific fear extinction is when you're trying to get rid of that fear conditioning, such as with the beep, where you actually have a fear response. In 2024, researchers Park and colleagues studied the effects of fear conditioning on a strain of mice with impaired fear extinction to model PTSD. So basically this means that we're looking at how fear conditioning affects mice if they're unable to get rid of that fear, so if they have impaired fear extinction. So these researchers found that fear conditioning in mice enhanced amygdala activity. And after these PTSD mouse models had failed to get rid of that fear, they had failed fear extinction, this enhanced amygdala activity was still present. Another strain of mice without impaired fear extinction also experienced increased activity in the amygdala after fear conditioning. But this gradually decreased after fear extinction. So this kind of shows that fear extinction allows the amygdala hyperactivity to kind of diminish. And so the amygdala now goes down to more baseline activity levels. So this basically shows that if you are unable to get rid of that fear, you have impaired fear extinction, then you might have a chronically hyperactive amygdala. But why is this important? Well, the amygdala is an almond-shaped structure in the brain, and it serves to help us determine the emotional relevance of stimuli. So this suggests that if there is chronic hyperactivity in the amygdala in PTSD, individuals will be more aware of certain stimuli related to their trauma, which causes fear and stress. There are numerous other hypotheses predicting the underlying mechanisms behind PTSD, but I won't go into depth about everything, or this podcast would be way too long. In brief, one theory is that decreased hippocampal volume interferes with memory in PTSD. Another hypothesizes that decreased activity in the prefrontal cortex leads to difficulties with emotional regulation and fear extinction, which I talked about earlier. So those are just a couple more hypotheses about the underlying mechanisms behind PTSD. Okay, so we can't determine exactly why Lucy developed PTSD, but we do have a better understanding of some of the factors that could have been at play. Now I'm going to shift and talk about what Lucy can do to treat her symptoms. One treatment that has been explored for PTSD is eye movement desensitization and reprocessing, or EMDR. During EMDR, therapists guide patients through bilateral stimulation while asking them to recall distressing memories from the trauma. Simply put, bilateral stimulation is when one side, for example the left side of the body, is stimulated, and then the right, and then the left, and then the right, over and over and over again. The theory is that this also stimulates the brain in an alternating pattern. This could look like fast eye movements back and forth, which is what is commonly used in EMDR, or it could also be alternating sounds to the left and right ear, alternating tapping patterns, etc. One common technique that some trained therapists use is waving their hand back and forth in front of a patient's face in a particular rhythm, while the patient tracks the hand with their eyes. And during this, the patient will be asked to talk about their trauma or think about their trauma. And the theory is that this is going to help them better process their trauma. The history behind EMDR is quite fascinating. It was discovered by accident by psychologist Francine Shapiro, who was taking a walk in the park one day and discovered that all of a sudden her distressing thoughts had diminished. She realized that while she was walking, her eyes had been rapidly moving back and forth, and she wondered if this might have helped her process her thoughts and feel calmer. After formal scientific investigation, she began trying this on her patients and found that they also felt calmer after this bilateral stimulation. As of now, scientists aren't exactly sure why and how bilateral stimulation works, and why it's so beneficial for PTSD patients. I'm always amazed by accidental discoveries that turn out to have a huge impact on science. This just goes to show that it's important to think critically and look for patterns and connections in daily life. So, researchers Matera and colleagues postulated that amygdala hyperactivity is one of the neural mechanisms underlying PTSD, which can negatively affect hippocampal memory consolidation, a concept that I touched on a few minutes ago. In a paper published in 2022, these researchers found evidence that EMDR works by using bilateral stimulation while psychologically distancing the patient from the trauma, which helps to engage brain regions that lower amygdala activity and induce slow-wave brain activity, allowing for more efficient processing of traumatic experiences. Another treatment commonly used for PTSD is prolonged exposure, which is where an individual is gradually exposed to cues that remind them of their trauma, so there is a reduced sense of fear and danger surrounding these cues. This is basically a form of fear extinction, which I talked about earlier. Individuals start off by recording themselves describing the traumatic event in detail. Then they listen back to the recording with the guidance of the therapist. After they become more comfortable with that, they are given assignments to expose themselves to trauma-related cues in real-life situations, instead of just in their imagination. So if we go back to the example of Lucy, if the traumatic event was a car accident, like in her case, then Lucy might first relive the experience in her head, and then with guidance from a therapist, she might begin to gradually expose herself to driving again. This could mean that Lucy just gets in a car one time. She just sits in the car in her garage, maybe. And then the next time, she sits in a car while her husband drives. And then the next time, she's the one that's driving, and she drives a short and easy distance. And then eventually, she will get back into driving normally as she did before the car accident. This breaks down the exposure into small, manageable chunks, so the patient is challenged with each new exposure, but it isn't completely overwhelming. Similar techniques are often used for other conditions, such as obsessive-compulsive disorder, including exposure and response prevention. So these are some therapies that can help with PTSD symptoms, but what about drugs? One drug that's starting to gain more attention in the field is MDMA, but it hasn't been approved by the FDA to treat PTSD as of now. and researchers are still determining how effective it really is. It seems to act by enhancing plasticity in the brain, which can enhance the effects of psychotherapy and trauma processing. Because I made an entire episode about the use of MDMA-assisted therapy as a treatment for PTSD, I won't spend a lot of time on it here. If you're interested in learning more about how effective MDMA is for treating PTSD, I encourage you to check out that episode. Some commonly approved drugs to treat PTSD include antidepressants such as SSRIs or selective serotonin reuptake inhibitors. In another episode, I can go more into depth about what this class of drugs is and how these medications work, if you're interested. But in essence, they act by increasing the activity of serotonin in the brain. Examples of SSRIs used for PTSD include sertraline and paroxetine, which are known under the brand names Zoloft and Paxil, respectively. While SSRIs don't fix the underlying problems caused by trauma in patients with PTSD, they can help patients manage symptoms by decreasing depression and helping with sleep. However, without proper therapy and processing of the trauma, drugs won't be very useful in treating PTSD. Okay, so that's a general overview of PTSD. I hope you've learned something new from this episode. The fields of psychology, psychiatry, and neuroscience still have a long way to go in explaining exactly what is behind PTSD and how to treat it. But currently, there's amazing progress that's being made. Thank you so much for listening to this podcast and expanding your knowledge of psychology, neuroscience, and mental health topics. I'm so grateful for the opportunity to learn alongside you. If you have the chance, please rate and review this podcast and let me know what you want to learn about next.